All right. Good morning, everybody, and thank you for coming to the Free Papers Session 3, Technology, AI, Digital Innovation in Metabolic Bariatric Surgery. My name is Ahmed Ahmed. I'm a surgeon from Imperial College London, UK, and my colleague is Dr. Ana Marta Pereira from Portugal. So welcome and thank you for coming for this early morning session. It's always difficult. First session of the morning after a heavy night, so well done to everybody. And we're going to try and keep on time, so would you like to introduce the first speaker?
Yes, please. So we're going to have Alexander Kitarian, and he's going to talk about predicting postoperative complications in metabolic bariatric surgery using machine learning methods.
Hello dear colleagues, we are very grateful to be here and the possibility to speak about our research predicting postoperative complications in bariatric surgery using machine learning methods. Today it's well known that early laparoscopy is the main tool after bariatric surgery. It can reducing the risk of abdominal sepsis, the risk of mortality, the length of the hospital stay, and early detective of complications significantly improves patients' outcomes and ensures more effective treatment. Now, this fact supposed a number of researchers, publications to early laparoscopy, and more authors focus on the need to assess the clinical conductions, but others studies focus on laboratory parameters like leukocytes, left shift in the white blood cell, C-reactive protein, and others like radiological, ultrasound, and computer tomography. However, in patients with a body mass index more than 50, these studies are often insufficiently effective, leading to delayed interventions when such complications develop. We analyzed more than 2,000 bariatric patients who underwent through MI gastric bypass, one anastomosis gastric bypass, and sleeve gastrectomy. We are looking for serious inflammatory in 28 cases. This included anastomosis leaks, staph leaks, and with development of abdominal abscesses. A detailed analysis of symptoms of these complications was conducted for primary selection of predictors, one-side ROC analysis, and of course we calculated. We didn't do it without the help of our statistics, and we found the most significant markers of inflammatory complications. You can see it on the screen, this visual analog scale of pain more than 4, further more than 38, heart rate, white blood cell count more than 13, etc. We used artificial intelligence for creation of this mathematical model, and after they got an area after the curve for each parameter set calculated, and then we created mobile application for our model with the AI. And now I would like to provide you some examples. First examples at 14 years old female patient after one anastomosis gastric bypass, BMI 47. On the third day, she presented with diffuse abdominal pain, further more than 38, and tachycardia after up to 110. No drain output. Clinical tests revealed leukocytes more than 14, bent neutrophils 9%, and C-reactive protein 137. We entered all parameters in our app and showed a high complication risk. This is what we saw during the original laparoscopy. It was a lot of pus near the trocar wounds and near the hepar, and it was just an abscess, abdominal abscess. We try 2 or 3 drainage tube. And finish the operation. Second example, 37 years old male patient after sleeve gastrectomy, BMI 45. The post-operative period was uneventful. The patient was discharged from the hospital on the 6th day. On the 9th day, readmission with slight abdominal pain further more than 37.5 degrees. Clinical tests revealed leukocytes 10, bent neutrophils 9%, C-reactive protein 130. We do it again, and it takes us a high complication risk, and we've done real laparoscopy. It was after sleeve gastrectomy. We had a leakage in the angle of his, and of course we use drainage tube. And because we do mobile application, you can try it for yourself and use it in your clinical work. Thank you for attention.
Thank you very much. So this paper is open for discussion. If you have a question, please come to the microphone. If I can just start by asking you a question. So you've used basically AI to develop a scoring system to screen or identify the risk of a complication, such as a leak. But when you feed the parameters into the model, you get a risk, but and then you decide to operate or not. But would you not do any kind of imaging at all? So these patients, the 2 examples you presented, I presume when they came back to the hospital, instead of putting their details into your model, you could have just done a CT scan and you would have gotten a pretty accurate answer as to whether they have a post-operative problem or not. So how come you've not included imaging into this algorithm?
All of this algorithm. We have a lot of operation, and we know, of course, who patients need real laparoscopy, who don't need it, but we try to use artificial intelligence. We help with our statistics, and
so you don't use a CT scanner? You don't use CT scan? CT scan? X-rays? CT scan?
What is it?
The image.
I don't understand. What is it? Image. Yeah, we have it, of course, but then patient has a great BMI, more than 50, 55. We can't use it, of course, and if they have one markers, like leukocytes or abdominal pain, we always can't start with real laparoscopy.
Okay. Thank you. Question from the audience.
Just thank you for your presentation. I may have missed that. What was the cause of the 2 findings you showed us on the video? What was the why?
We just use this model on these patients, and for example,
But what did you find? I mean, what was the source of the complication?
first patient was abdominal abscesses, and the second, the staple leakage near the angulogis.
Okay.
Thank you. Thanks very much. We're going to get the next patient, I said, next presenter up. Can we have Dr. Ala Zawefi, please, from Egypt? And he's going to talk to us about single anastomosis, sleeve jejunal bypass, review of 6,000 patients and 10 years of experience. Thank you.
Good morning, everybody. My topic today about single anastomosis sleeve jejunal bypass, or SAG, review of almost 6,000 cases and 10 years of experience. We have nothing to disclose. Early in our surgical practice, most of cases are were either laparoscopic sleeve gastrectomy or Roux-en-Y gastric bypass, but we noticed that many cases return after sleeve gastrectomy for reduced surgery due to weight regain, and also Roux-en-Y gastric bypass is complex and very difficult in high BMI, and also its revision is not easy. So with the emergence of one anastomosis gastric bypass, we incorporated in our surgical practice with good result as regard weight regain, as regard weight loss, but we also reported cases of malnutrition. So with the emergence of SASI, or single anastomosis sleeve ileal bypass, it attracted our attention, and we thought that it may solve all these issues associated with other procedure. And we tried as an investigational procedure and published our multi-center study about 8 years ago. But also during the follow-up, we noticed that many cases developed protein malnutrition or excessive weight loss due to short common channel. Also, this is reported in literature. For example, in this study done by Kerman Serifali et al., they found that SASI associated with excessive weight loss and protein energy malnutrition. Also, in another study done by Ahmed Kamal et al. From Egypt, also they found that SASI associated with severe malnutrition and unpredictable weight loss. Another study from Ala Wafa et al., they found also that SASI associated with alarming malnutrition. So that we decided to shift from SASI with short common channel to SAG with a long common channel to overcome this nutritional complication. And we published the first study of 2 years follow-up about 7 years ago, with conclusion that SASG is associated with least nutrition deficiency. Then we published our largest series all over the world, and about 6 years follow-up, with conclusion that SASG is a good metabolic surgery without significant nutritional deficiency. Also, we tried the SASG as a revisional procedure after failed laparoscopic sleeve gastrectomy or adjustable gastric band, and the conclusion was that SASG is effective as a salvage surgery after failed restrictive bariatric procedure. Recently, we published our clinical trial comparing SASI to SASG, with conclusion that SASG is associated with less complication rate and less nutritional deficiency compared to SASI. From 2015 to 2025, total patient operated with SASG in our private clinic and in our university was about 5,782 patients. Patients who complete 1 year follow-up were about 5,000, and the patient who completed 2 years follow-up were about 4,500 patients. Patients that completed 10 years follow-up were about 59 patients. How to do? As a standard for sleeve gastrectomy, we begin to dissect the greater momentum from the stomach down to the pylorus and up to the left crust of the diaphragm. Then we begin to cut the stomach about 6 centimeter from the pylorus, and we continue cutting the stomach upward using 36 French bougie. We routinely invaginate the stable line to minimize the incidence of bleeding and leakage. Also, we routinely fix the stomach to the prepancreatic fascia and to the left crus of the diaphragm to prevent twist or migration of the stomach into the chest. Then we begin to count the total intestinal count from the DG to the ileocecal valve. Here's the DG. And at about 25 count, we ask the assistant to grasp the small intestine by soft grasper, and then we continue to count the total intestinal count till we reach the ileocecal valve. Here we reach ileocecal valve. The total count in this case was about 90, so we add to the point of assistant grasper 5 count to make the anastomosis at junction between the upper 1/3 and the lower 2/3 of small intestine. Then we do the anastomosis using blue cartridge 35 to 40 transverse in manner. We operated SSG as a primary operation in 4,835 patients and in reduced surgery in 111 patients. The mean BMI was about 47. As regard complication, all complication was reasonable, as you see in this table. I want to jump. But the most common and irritant complication was biliary vomiting. The incidence reached up to 8%, but in most of patients, it managed by conservative treatment. As regard with loss, BMI dropped from 47 to 25.7 at 2 years and 30 at 10 years. As regard the admission of comorbidities, type 2 diabetes remitted in about 96%, hypertension in 98%, hyperlipidemia in 89%, sleep apnea in 98%, GERD in 80% of patients. So we can conclude that surgery is effective as a metabolic and bariatric operation, but the result depends on 3 technical parameters: the size of the pouch, the size and the site of the stoma, and where we do the anastomosis in the small intestine. And after 10 years of experience and about 6,000 cases, we can conclude that the optimal pouch size was 36 French. Stoma size is 35 to 40 transverse at the greater curvature. And we do the anastomosis at the junction between the upper 1/3 and the lower 2/3 after counting the total sound count. So the result is a new form and good for all patients. Thank you.
Thank you very much.
Okay. My name is Piotr Myśliwiec. I'm from Poland. Congratulations, large number of patients. Did you have to convert this operation to the Roux-en-Y configuration for biliary reflux?
Yeah.
How often?
I have, as I said, the most common complication and irritant for the patient and the first surgeon is biliary gastritis or biliary vomiting. In most cases, it was managed by conservative management, BBI, sucralfate, modification of diet. But in about 14 cases, I converted to transit bipartition Roux-en-Y Santor operation.
Did you have any internal hernia?
No, at all.
I have a quick question. This is your standard procedure, as I understood. So, do you choose? Do you have another procedure for any algorithm or you use this procedure to every patient?
I do Roux-en-Y gastric bypass in severe GERD and huge hiatus hernia. sleeve laparoscopic sleeve gastrectomy in selected patient when I afferent from malnutrition in old age and in young age. Also, when the patient suffer from malnutrition perioperatively.
Thank you. We are out of time, so I'm going to present the next speaker. Thank you very much. It's Lara Hernandez Velez from Spain.
Hi, good morning. Thank you for coming, and thank you for giving me the opportunity to present my project, which is called Conventional Ultrasound versus Attenuation Imaging, ATI, for hepatic steatosis in bariatric surgery candidates. Nothing to this class. As you know, non-alcoholic fatty liver disease is most common life disease worldwide. It's considered as the hepatic manifestation of metabolic syndrome. Is the excess of accumulation of fat more than 5% on liver weight is NALF, and NAS is the progressing form of NALF. As we can see in the map from Journal of Clinic Translation Hepatology, there are more countries with more than 20% of prevalence of NALF, and in pink one we can see more than 30%. So we saw a problem. NALF is highly prevalent in severe obesity, and is a key comorbidity in the metabolic bariatric surgery candidate, affecting surgical risks and preoperatory management. So we see the limitation with the conventional B-mode ultrasound is the most widely used screen tool, but this diagnostic accuracy is limited in this population due to obesity-related artifacts. So we saw the opportunity. ATI is an emergency quantitative ultrasound technique that may enact no invasive assessment of hepatic steatosis in this setting. So we make the key question: can ATI outperform conventional ultrasound in detecting hepatic steatosis before MBS? And you use histopathology as the gold standard. So our objective is compare the diagnostic performance of conventional US versus ATI for hepatic steatosis. First of all, we take our population, we take consecutive MBS candidate, our N it was 38. We did the intervention, the same radiology did before the surgery, the B-mode US and the ATI. And we take intraoperatory the biopsy liver. We design our study. We did prospective observationality study. We take the consecutive MBS patient, and we just did here in Malaga in one hospital. Preoperatory, the same radiology do the visual ultrasound grading, and we did in a scale from 0 to 3. We did the ATI, they give a number, a measure, so it's a quantitative measure. And later, intraoperative, we take the biopsy, the liver biopsy, and we did by Brown classification 2 to 0 to 3. We did the analysis, the statistic. This is our result. As we can see, ATI in green shows substantially stronger correlation and better agreement than the B-mode ACE compared with histopathology. And if we saw the last line, the exact agreement rate ATI is near double than a conventional ultrasound. So it demonstrates its superior ability to match the histopathology grade. If we analyze it separate, we can see in the ATI from S1 or more, the sensitivity, it was 80%. So ATI correlated identified 4 of these 3 true calls. If we saw the specificity for ATI, it was 92%, so it was very few false positive in no steatosis liver. And for us, this is one of the most important data we found in clinical significant steatosis, more or equal S2. The ATI specificity is close, is near 100%. So they limited false positive to moderate or severe steatosis. We see here a critical important in the preoperatory surgery planning context. This is the result summary we find. As we result, the specificity for ATI in more or equal S2. But how can you, this is important in clinical implication. So first of all, with this tool, we can stratification the hepatic risks in our operative. We can plan in better surgery. Maybe avoiding necessary biopsy in this patient, we say more than S2. because maybe we don't have to do invasive tools, invasive assessment in the preoperatory workup. And finally, we have to remember that ATI is no invasive integration, and they give us like a number measure, so it's not such an intraoperatory, I don't know how do you say, the difference between two persons taking the same tool, like a B-mode EUS. So as a conclusion, we can say ATI demonstrates superior correlation with histopathology, comparison with conventional ultrasound. ATI achieved better agreement with histopathology steatosis grading than the conventional B mode. For the detection of any steatosis, ATI saw good diagnostic. ATI demonstrate near perfect specification for clinical steatosis, and ATI may represent a value, no invasive upgrade to standard preoperatory ultrasound in this program, in this patient. Thank you so much.
Thank you. This paper is open for discussion. If I can just ask you a question. So I'm not familiar with radiology and ATI scanning, but in the UK we have something called FibroScan.
Yeah.
And is this technology ATI different to FibroScan? And if so, how does it compare? Because I'm informed that FibroScan is pretty accurate for NAFLD.
FibroScan we use here too, but it has limitation for obesity patient, or maybe if they have some primary illness in the hepatic, in the liver. So ATI is completely different. It's like echo B mode. They same in the same time with the same echo, but they measure the impedance of the tissue. So they give you like 3 different measure with number, and depend of the scale, they classify in different S0, 1, 2, or 3. But it's completely told different. It's new, so they are just doing, this is the first study here comparing 80 mode B, that this is like the normal, the regular way we do before the surgery. And the FibroScan, we are not comparing. This is just with B mode, because
But which is better, FibroScan or ATI? Or you don't know?
This is a preliminary result. We only have 38 patients, so I think it's a little bit early to know. But in my opinion, I think this is really it's a good. I think this is better.
Okay, perfect. Thank you very much. Thanks a lot.
I have one question. I know this is a short quote, but how often, if it was possible, did it change the surgical planning in this quote, if it changed?
Change the surgery, the planning of the surgery?
Yes, yes. How many times did you have to change the type of surgery that you proposed to the patient?
Okay.
Compared with the conventional ultrasound?
Okay. This study is not for change now the planning. Here in Spain, we did the echo in V mode, just to know if they have some in the, I don't know how to say, of vesicle. Yeah, so it's like a screening.
Okay.
So we just use this study to compare to see if this tool it could be useful for this one and for other studies, but not to change the planification. Maybe you can know that if you have more risks of the liver can be bigger, or it can blood something more, but not to change the planning of the type of the surgery you did.
Thank you.
Thank you.
Thanks very much. Could we have the next speaker, please? Swana Kempegowda from the UK, speaking on concordance of large language models with consensus principles for GERD management in patients with obesity.
Good morning, everyone. I'm Swarna. I'm a resident doctor from the UK, and I'll be presenting a paper which is the concordance of large language models with consensus principles for gastroesophageal reflux disease management in patients with obesity. No conflict of interest to declare. A bit of a background, as we all know, GERD is highly prevalent in individuals with obesity. It's frequently refractory to medical therapy, and obesity contributes via increased intra-abdominal pressure and altered gastroesophageal junction physiology. Metabolic bariatric surgery, particularly RYGB, provides durable reflux control and concurrent metabolic benefits. LLMs are emerging in clinical decision support. It's being used quite often, not just with patients, often with doctors as well. And it's unclear whether these LLM outputs align with the established surgical consensus. So the aim of the study was to evaluate the degree of concordance between multiple popular LLM models and consensus-based principles guiding the surgical management of GERD in individuals with obesity. So we derived about 25 clinically relevant statements which were developed from international bariatric and foregut principles and guidelines and consensus documents. We covered multiple domains, including the pathophysiology of GERD in obesity, procedure selection, revisional surgery, hiatal hernia management, and preoperative assessment. The three large language modules that we independently used were these, and the output classification was simply derived into agree, disagree, as well as the supporting rationale for the same. The analysis for the intermodal agreement was assessed using Fleece-Kappa score, and a qualitative analysis of disagreement patterns was noted as well. So these are the domains that were evaluated, and some of the key organizations from who we derived these statements was IFSO, MBS, SAGES, the NICE guidelines as well. So with the statements, we arrived at an overall agreement of about 94.7% with a Fleece-Kappa score of 0.31, which shows moderate agreement. So to interpret it, there is high raw agreement across the models for these guidelines, and a moderate Kappa score which reflects category imbalance, which is Kappa paradox. There is a high raw agreement, so there will be a bit of a Kappa paradox that we would note. Possibly moving forward, it would be a better idea to have other statistical models in place to avoid a paradox. So overall, there was high concordance despite statistical limitation. The areas of agreement that we noted were mainly talking about obesity being identified as a key driver of GERD, RYGB being recognized as the most effective procedure, and weight loss being central to GERD management. And the areas of disagreement that we noted were mainly about redo fundoplications, isolated hiatal hernia repairs, and these are areas that already have limited high-level evidence and significant clinical variability. It does differ from patient to patient, and it reflects a real-world decision-making uncertainty, not just a model error. To interpret it, there is strong alignment with established principles, and LLM does output current bariatric surgical thinking and multidisciplinary practice patterns, and disagreement is mostly in the complex individualized decision scenarios. So LLMs do capture both consensus and uncertainty at this point. So to conclude, it does reflect real-world practice rather than inconsistency. There are limitations to the study. One could argue that there is a certain level of choice that has been done by myself and the researchers where we derived it and we ensured that we were covering each domains equally. So maybe moving forward we would include more number of ones and we would not be selecting them and handpicking them. That could possibly change the outcomes. The further implications at least is to look at a potential role for LLMs as adjunctive clinical decision support tools and must be used alongside clinical judgment and a multidisciplinary evaluation and not replacing surgical decision making. Thank you.
Thank you very much. Is there any question for the audience? Just to put it all together, are we validating the LLMs, or are we just simply showing that they can reproduce the guidelines that already exist?
I think at this point we are looking more into showing that they can reproduce the guidelines that is being followed. But I think this was a pilot study to look into seeing if we can use the existing LLMs as an adjunct, because patients are already, when they come into clinics, they already come in with a chat GPT and a Claude and a Gemini answer. That is something that we are seeing in clinical practice at this point. So if it does have a role, and if we can use it as a triage material possibly, or as an adjunct, and maybe to ease the burden on the existing healthcare system, then why not? But to do that, we'll have to first establish that this is safe, it agrees with the international consensus, and then move forward.
And so it's safe for the patient to ask to ChatGPT.
Well, they're not going to stop. They're going to do it anyways. Might as well make it safe in the process.
Thank you.
Thank you.
So the next presenter is Cynthia Moufignon from United States. Welcome.
And thank you very much for inviting us to present our findings on post-op bleeding and the robotic platform, and for coming to this absolutely beautiful city. And I have no disclosures. Post-op bleeding is one of the most frequently occurring major complications of metabolic bariatric surgery, and the robotic platform has a number of features that can help to reduce tissue trauma and the risk of bleeding. So, our objective, the primary objective, was to determine the incidence of postoperative bleeding following totally robotic versus laparoscopic primary metabolic bariatric surgery, and secondly, to compare early surgical outcomes of the robotic and laparoscopic approaches. Our study included 922 primary surgeries performed laparoscopic or totally robotic by a single surgeon who was trained in robotic technology. 56% of surgeries were sleeves, 44% gastric bypass, and there was no difference in distribution between the laparoscopic and the robotic approach of these procedures. Now, all our patients were under the same ERAS protocol, and both the laparoscopic and robotic surgeries were anatomically the same, except for the port site locations. For the Roux-en-Y gastric bypass, surgical details were identical between the laparoscopic and robotic approach, including the performance of the anastomoses, which were with the same technique, hand sewn for the JJ, the JJs both stapled and hand sewn. Both the robotic and laparoscopic sleeve gastrectomy were anatomically the same, except there were differences in the types of staplers that were used to create the sleeves. Study measurements included patient characteristics, op times, length of the hospital stay, 30-day readmissions, reoperations, complications, and postoperative bleeding. We found that patient characteristics were similar between the laparoscopic and robotic groups. Age averaged 45 years for both, BMI 46 for both, gender distribution was similar, and the number of obesity-associated health issues was nearly identical, 2.74, 2.71. Incident rates for the individual health issues were also similar between the laparoscopic and the robotic patients for sleep apnea, type 2 diabetes, hypertension, dyslipidemia, GERD, cardiac issues, and even depression and anxiety. Op times were from the initial incision till the application of the dressing, and for the robot that included both docking and undocking. Op times were significantly shorter for the robot compared to the laparoscopic procedure, 19 minutes shorter for the gastric bypass, 8 minutes shorter for the sleeve gastrectomy. The length of the hospital stay was also less with the robotic platform for both the gastric bypass and the sleeve gastrectomy. 30-day readmission rates were lower with the robot overall, 2.8% versus 6.2% for the laparoscopic approach. Reops tended to be lower and significantly so for the sleeve gastrectomy. And major complications were less with the robotic platform versus the laparoscopic procedure for both the gastric bypass and the sleeve gastrectomy. Overall, average robotic major complication rates were 1.4% and 5.1% for the laparoscopic approach. Now, postoperative bleeding for the laparoscopic approach was the most frequent complication. Overall incident rates were 2.9%, 3.4% for the gastric bypass, 2.5% for the sleeve gastrectomy. With the robotic platform, it was 0.15% overall, which represented a relative risk reduction of 94.8% or 19-fold lower bleeding risk over the laparoscopic approach. The bleeds occurred early, 89% in the first 72 hours. Management included surgical intervention in 44% of patients, endoscopy 33%, and transfusion with support management in 22%. Between patients who had a bleed and those who did not have a bleed, there were no significant differences in age, body mass index, number of obesity-associated health issues, gender distribution, or op times. Length of stay, however, was significantly longer, 2.76 versus 1.22 days. So overall, for primary gastric bypass and sleeve gastrectomy, the total robotic approach significantly reduces post-op bleeding and improves surgical outcomes, yielding shorter op times, length of stay, and fewer 30-day readmissions, reoperations, and major complications. The end.
Great. We're going to open this paper for discussion. Can I just quickly start by asking you a question? What was your criteria or definition for post-operative bleeding? How was it diagnosed?
It was a hemoglobin of greater than or loss of, or reduction in hemoglobin greater than or equal to 2 grams per deciliter and requiring intervention.
Okay, thank you.
And with symptoms, of course, hypotension, tachycardia, melena, in some cases.
Congratulations for your presentation. How would you explain this striking difference?
How would I explain, pardon? Oh, between the robot?
Yes.
Oh, golly. Well, there's many features of the robot that reduce tissue trauma and therefore bleeding. First of all, you have greater precision as a result of the tremor control and the 3D high definition vision and the wristed instrumentation, the larger range of motion. And so that would help with, at least with the that aspect. And then we would have the reduction in torque, which would reduce port side trauma and bleeding. And then there is the articulation of the instrument tips, which would reduce tension and therefore tissue bleeding. Well, let's see, what else?
Your rates of complications after laparoscopic surgery seem rather on the high end of what we usually find in life. I wonder what was the experience of the surgeon in laparoscopic surgery and in robotic surgery before you started this comparison?
Laparoscopic, he'd done thousands. This is Dr. Smith, as you saw earlier, and he's done many laparoscopic surgeries. He was very stubborn about changing over to robotic. And Keith Kim, the rest of the folks with us, all did robotic surgery. And he finally transferred to robotic and was amazed at what he was finding. So that was about in 2018, 2019. So he was experienced.
Thank you. Arif Ahmad from New York. Thank you for a great presentation. It's one of the few papers, that really show that the robotic approach is significantly better than the laparoscopic approach. I myself am a big proponent of the robotic approach. We've done about 5,000 robotic bariatric surgeries. When you look at, there was a publication, we're part of that included, novice centers as well as experience centers, and had about 10,000 patients. It was an international database kind of a thing by Guidicelli. It was in the British Journal of Surgery, if any of you have seen it. It really showed that the operative times were a little higher with the robotic approach, just to put things in perspective. And the complication rates, at least in the expert centers, were about the same. Bleeding and other things. Our own data, and this has been published in Surgical Endoscopy, and we have some additional data that's being published shortly, shows that our operative times are about the same now, having done more robotic cases, and the differences are about the same, really. Not much difference in bleeding, or not such a big difference as you've noticed. Now, obviously, this could depend on the fact that either the group that's doing it is not very good laparoscopically, and therefore taking longer, or they're very good robotically. I mean, there's so many variables here that you have to look at. That's why it's good when you come to an assessment like this to look at multiple centers rather than one particular thing, because it's obviously prone to the error of thinking that robotic surgery is better or laparoscopic is better, because you'll see data across the board. Some will say laparoscopic is better, and it's very confusing for a lot of people. So, but thank you for that presentation, because it will support us who are proponents of robotic surgery.
Keep in mind, this is single surgeon, and so we don't have all the variability in surgeon experience with the robot. We don't have the variability with the op times with the what am I trying to say here? Anyway, we just find that in a single surgeon setting, that this was our findings. We were pretty amazed too. Dr. Smith said he didn't care whether what I found when we were analyzing the data. We pulled the latest data from the data center, and he said, I don't care what you find. I'm not going to go back to laparoscopic. He said, because I go home and I can play with the dogs and the kids, and I feel so much better. Anyway, but we're from a center that, since robotics has started, that has very much promoted robotic surgery. And so we're well experienced in the process. And this, again, is a single surgeon's findings.
Thank you.
Is
We
that
have
all?
to
Any
begin.
more?
Thank you for your presentation.
Thank you.
Now we have Alex Diaz-Quiles from Spain. He's also going to present about robotic platform.
Good morning, thank you.
Discuss one more.
I'm Alex Diaz. I'm coming from Hospital Germans Trias i Pujol in Barcelona, and I'm going to present you our results in revisional metabolic bariatric surgery using a robotic platform. I have nothing to disclose, and the aim of this presentation is to share our experience with revisional bariatric surgery using a robotic platform from its implementation at our center in 2017 through 2025. We have seen an increasing number of the revisional bariatric cases until 2022. At this point, we can see the curve stabilizes and a slight downward trend, coinciding with the introduction of the incretin-based therapies. But the question is, are we in a real change in this trend, or it's just these treatments are including in our treatment? In any case, the pharmacological treatment can change the indications, but there are some cases that the surgery has a definitive role, like the anatomic complicated cases. If we take a look in the 2024 IFSO registering data, we can see that the 20% of all the revisional cases were performed by robotic surgery. In Spain, if we see the SECO registry data, we can see the similar trend. There's a change in the last years in the complexity of the cases that we treat, and there's a fewer indication in grade 1 and 2 obesity, and a greater proportion of obesity in grade 4 and 5 obesity, as well as revisional surgery due to the therapies I mentioned before. And it's for these technical cases that the robot give us some advantages. As you can see on your left side, laparoscopic procedures, and on your right side, robotic procedures. We can see that robotic can give us better visualization, better movements, and ergonomics for the surgeon. It's for these benefits that in 2017 we began to use the robotic platform, and in 2018 we launched our robotic and revisional bariatric surgery program, and we have performed 546 robotic bariatric procedures, and as you can see in 2022 these procedures were more frequent, and in between 2022 and 2025 the 75% of cases were performed in this time due to the learning curve. The most common indication of revisional surgery in our center was conversion, about 70% of cases. The first indication was patients with a previous sleeve gastrectomy and gastroesophageal reflux disease. The second indication was sequential procedures, and a small part for corrective procedures. And if we see the variables that we have studied, we can see the median age in our group of 54 years old, and a BMI in the revisional group of 38.7. And in the clinical variables, we can see the high prevalence of GERD in this group, until 65%. If we see the operative variables, we can see that the operating time median is 181 minutes, and it's stable over the time due to the learning for the surgeon, but twofold all the operating room team. In our area, mortality and intraoperative complications recorded was 0. And if we see the complications in these patients, we have 2 cases with Clavien Dindo 2 resolved without need of surgical treatment. One of them was an intra-endoluminal bleeding resolved spontaneously, and the other one was a patient with multiple comorbidities compensated in the postoperative course. One patient needed reintervention because a leakage in the biliary, anastomotic biliary. Between since 2015, 33 laparoscopic cases were performed and 88 robotic cases were performed. If we see the comparison, operating time was similar in both groups, and it's notable that in the last case that we made with laparoscopic was in 2024. In 2025, there's any case with laparoscopic approach. Comparing groups, we can see that morbidity is lower in robotic group, and the hospital stay is shorter due to less pain and a faster recovery. And we can see we compared the weight loss and the weight maintenance in time in these 2 groups, and we see no difference between groups. And we see a total weight loss stable over the time. And this is the results of our patients. And in summary, we can say that revisional bariatric surgery is now a well-established and necessary component of obesity treatment. Robotic surgery offers clear technical advantages in precision, dissection, and visualization, especially in complex revisional procedures. Weight loss and metabolic outcomes are comparable to laparoscopic, with a trend toward lower morbidity and shorter hospital stays. In the current context, robotic revisional surgery should be considered the approach of choice whenever available, within the comprehensive and personalized management of obesity. Thank you.
Thank you very much. This is open for discussion. So let me ask you this question. If you have a problem when you're doing your robotic surgery and you have to convert, do you convert to laparoscopic or do you convert to open?
No, I think that convert to laparoscopic, it's not the best option because the positioning of the trocars, you will not comfortable with the laparoscopic instruments. So I think it's better to convert to open surgery from robotic than no from robotic to laparoscopic.
Okay, thank you.
Congratulations for your work. We don't expect to have different outcomes in terms of weight loss and metabolic outcomes with this platform because the surgery is the same, the technique is the same. We expect better ergonomics and feasibility to do more complex cases. And here I see that you have a really fast docking, which means that you have a really experienced team, but you have long operating times. And so my question is, this reflects the complexity of the cases, or you think there is a room for improving the technique with robotics and is going to have better times in the future?
I think the time, if you see all the times between the years, there's a learning curve, not only for the surgeon, for anesthesia and nurses, all the time. And we expect that the time is lower over the time.
Thank you.
Great, thanks a lot.
Thank you.
So our final speaker is Martin Fried, who's going to talk to us about magnetic versus staple technique in transit by partition one-year outcomes.
Good morning. I appreciate the opportunity to talk, and I have nothing to declare in regards of this study that I am going to present. So it has been already stressed here yesterday and during other opportunities that only about 1% of the potentially eligible patients for metabolic bariatric surgery really get the treatment. And there are several reasons for that. And one of the reasons is that the patients fear the invasivity of the procedures, they fear potential complications, and last but not least, they also are concerned about the necessity of lifelong changes of their lifestyle. So those are the things that mostly influence the patients to rethink whether they really are going to undergo metabolic bariatric surgery. So in regards of the magnets and the other things, I have a 20-second quiz question. If you are a patient and someone tells you, okay, I can do technically one procedure, but it either needs this kind of an intervention, which is not too aggressive, but needs this one, or you can have the same thing done like this. So what would you think the patient will say? Yeah, I think that the answer is obvious. So this is why the new era is needed to introduce new technologies that are not that aggressive, invasive, however, which will show the patients that even surgery can be gentle and have as low as possible complication rates. So our study aim was, and it's a very small study, limited study, to compare the magnetic versus stapled GI bipartition in regards of the technique. Please note that this is what I'm going to talk about and talking about. It's not about the procedure per se. We can talk about the procedure hours, but anyway, this is about the technique of making a side-to-side jejunal-ileal anastomosis. So the established GIB technique is this one, and you saw that already, and this is the result. I mean, it's not bad, but you can see some of the staplers there, you can see the stitches when the bowel surfaces were brought or approximated, and this is how the GIB technique works. The black arrow is the old route, the yellow arrow shows the, let's say, cutting, the expedited flow of the food, and this is how the food comes back from the long limb of the intestine. So our hypothesis was to whether the magnetic anastomosis is going to create a non-inferior outcome or have a non-inferior outcome in regards of weight loss and metabolic outcomes to the established technique we use with staplers and hand suturing. So this is the magnetic part, and you can see the result on the right side that the healing of the two bowels is really with almost no scar left there. So the study setup was a comparative, non-randomized, non-inferiority study, and we evaluated the results of magnetic versus stapled GIB, and those are the parameters of the patients that were included. So you can see, apart from weight, they were well matched, and those are their parameters. So in regards of the outcomes, of perioperative outcomes, you can see that the time of the magnets is almost the same as the stapler technique. The reason is that that's results of our very first experience with the magnets. So there was an element of learning curve with the magnets, because otherwise the magnets are quicker than the staple technique. You can also see a difference in patients who were able or who swallowed both magnets. So it's much quicker than if one magnet has to be introduced or both magnets via endoscopy, gastroscopy. The same applies for the length of hospital stay. The reason why the magnetic patients stayed longer than the stapled patients is just because that was a study done on magnets. So we were wanting to be sure that they leave hospital in a proper stage. So those are the results, and you can see that the only difference is in the weight loss, but that was also caused by the inclusion criteria. Otherwise, all the criteria that were followed up showed non-inferiority of the magnetic anastomosis. This is again just another graph showing the same results. So the conclusion of what we studied is that the evidence demonstrates, limited evidence, please just don't get me wrong, that the magnetic GIB technique achieved metabolic outcomes non-inferior to those of stapled GIB at 1 year. So the magnetic anastomosis is being, at least from this point of view, equivalent to procedures where the stapled anastomosis is used. it's for sure, and we have got also histology of the anastomosis, but I don't want to prolong this talk. It exhibits decreased invasivity and maintains efficacy and safety as the established technique of stapling. So thank you very much for your attention.
Thank you for it's a very nice study, and we're going to open it to discussion. But one quick question, and I know you're not. You said you didn't want to discuss the operation, but I have to ask this: is how did you get IRB approval to do a GI bypass when it's an obsolete operation, which most, I guess, bariatric surgeons would think that it should no longer be done? So how did you convince the ethics board to give you permission to do this?
Okay, first of all, probably you're talking about a different, because this is a partial bypass, a partial bipartition. It does not exclude the rest of the length of the bowel. So, and we did studies that about 50% of the food goes the old long way, and about 50% goes the shorter way. So it has nothing to do with the former bypass procedures, which I agree are obsolete, but this is a totally different thing. And basically this kind of bipartition is used in many other bariatric procedures, together with a stomach surgery or whatever, but it's used, so it's nothing new.
Thank you.
Thank you for that presentation. So, you know, the outcome in terms of weight loss for any of these procedures, when you have a bipartition, depends on the size of that jejunal-ileostomy. Now, you know, the magnets come in 3 sizes, as you know. There's a bigger one, which is 6 centimeters. Which one did you use? Because we've used the smaller one, and we are not seeing additional weight loss. But, you know, we are going to use the larger one in future. So I think the important point in this paper is to present the size of that anastomosis, number one. And I think the second point is, you know, the main advantage of the magnetic technique is the fact that the anastomosis forms over time. Therefore, the chance of bleeding or leaking is virtually zero. And also, you're not making an enterotomy. You don't have to close an enterotomy. I think those are the advantages. So if you see an advantage, it would be more in the perioperative outcome. And if you see an advantage in the weight outcome, then it would depend on the size of your stapled versus magnetic. Otherwise, the operation is the same.
Yeah, exactly. I agree. The magnets are in 3 sizes. It's 60 millimeters, 70, and 80 millimeters. The 80 millimeters, nowadays, the 80 millimeters is used usually for gastroenterostomy from this point of view. The 60 millimeters is used for the enteroenterostomy. Basically, it's very similar because we use the 60 millimeter cartridge for stapling. So the magnets are very similar to that. It's 60 millimeters. Don't get me wrong, the anastomosis per se is because it forms then a ring, and the ring is not 60 millimeter in diameter. It's smaller than that, but it's similar to that achieved with the stapled.
Just for your information, we don't have an 8 centimeter or 80 millimeter stapler magnetic. I mean, not stapler, but I mean a magnet. We don't have that in the US. So if it's available here, that's different from, maybe it's not FDA approved. Our biggest size is 6 millimeters, 6 centimeters.
Yeah, I agree. Unfortunately, in the US, you're ahead of Europe because FDA approved at least the 60 millimeter magnets, as far as I know, but in Europe, they are not approved yet. So it was under the study, the IRB and all these things.
Just a curiosity. When you show those videos, 30-second videos, and you show to the patient which one you want, and it seems that the patient wants the less invasive one, but when they swallow the magnets, then you have to position the magnets, and so you have to manipulate the bowel to position the magnet, and this is not less invasive. At least I think. You have to milk the magnet to the position that you want to.
Yeah.
Can you comment this? Because I don't have experience with magnets. Yeah. It's a curiosity.
Okay. So first of all, we don't show patients those videos, and we don't give them the quiz questions. It's for you guys here, not for the patients. That's the first thing. The second thing is, it depends, because I don't think so. Because you serve the magnets through the bowel, okay? You have from the interior wall of the bowel, you have a magnetic stick, and then the magnet has been swallowed, and it's intraluminally. So you serve that. And when you use a proper magnet force, not too much, you know, to really drag it, but if you use the proper, and that's the reason why there is a learning curve, but if you use a proper force, it just slides or serves through the bowel very easily. The thing is that the bowel can get constricted because of its natural function, then a Buscopan applied by the anesthesiologist intravenously will solve the whole problem. And then you serve very easily through the bowel wherever you want to.
Thank you.
Martin, quick question. Can you give us an indication of the relative cost when you compare the laparoscopic versus the magnetic? Which is more expensive?
Well, I don't know the U.S. experience. I'm not aware of that. Unfortunately, as I mentioned, it has not been approved yet in Europe. What I would expect is if it goes somewhere nearby, I'm not a businessman and I'm not being able to, let's say, set up a price of magnets, but if I was in this position, I would say it should not exceed the costs of stapler.
Just to give you perspective for those of you interested. So in the US, it's actually cheaper for us because we send them home the same day.
Okay.
Because really you're not doing any procedures, basically just you're doing a laparoscopy. You're not doing an enterotomy, you're doing an endoscopy to put it together, and the anastomosis hasn't even formed. It will form over the next 3-4 weeks.
Yeah.
So we let them go home. I'm surprised you kept them for 4 days, but that's like unheard of us for us. We would just send them home the same day, unless if they had an ileus or something like that. So it works out cheaper from that point of view. In terms of the staples itself, it's actually cheaper to use the staples. And then it takes a little bit less time when we do it. So if you take the time in the operating room in the US, that's very expensive.
We kept them for 4 days in hospital just because of the study. Not this study, but the former study 2 years ago when we did a proper magnetic study. And that was just for the purposes of the study.
Yeah.
And Arif, can I ask you, do you use the robot to put the magnets or do you laparoscopic?
So no, we do that laparoscopic, but it can be done with the robot. I think, contrary to what Martin mentioned, that it's very easy to surf the magnet through. It's actually not, in my experience, because you can tear the bowel as you're doing that. It catches it pretty tightly, and sometimes you're trying to reposition it. You have to twist it, and if you don't twist it properly, just try to pull it, it'll actually tear. So a lot depends on the friability of the bowel. And the other issue is sometimes when you're pulling it up to bring it to the duodenum with that heavy magnet in there, you're pulling it with the stapler, you can tear the mesentery. Serosal tears have been the main cause of leaks. It's not serosal, but full thickness tears. Serosal tears are quite common when we do these.
Well, I agree that you have to be very aware of potential serosal tears. But on the other hand, again, I have to repeat it, if you use appropriate force of the stick with the magnet, you would not tear the bowel.
Yeah, there's a bit of a learning curve in that.
Yeah, it is. Yeah, it is.
Yeah, well, I think one last question. Yeah, go ahead. Yeah. You can speak loud if you want. Yeah.
You have some cases where the magnet don't work, that they are not one in front of the other after the surgery.
Well, they click together. And that's it. They stick together. Yeah. And in about 2 to 3, in about 2 to 3 weeks, they just create a necrosis of the bowel wall. Sorry? Well, anything can happen, but it's not. It's highly unlikely, put it this way, because I can't see any reason why the magnet should twist or be in a different position than they were clicked together. Yeah.
Great. Okay. Thank you very much indeed to all the speakers for today. This is the end of the session, so I think you have a coffee before the next session starts. Thank you.